Thank you very much, Maria. I know that the time is not the best to keep you awake, but hopefully I will manage it. So what I represent you today is actually not the official position of the ICRP, but it's the work in progress of TG109, which has as a title what is written here, which is also the title of my presentation. So maybe it's good that you know what is the mandate that our task group received. So first of all, we have to develop on the ICRP publication that present ethical aspects in the use of radiation in medicine. So medicine is really the important word. And we are not dealing with ethics related to the dose received by the personnel, but we are dealing with radiological protection of patients. So this is really patient-centered. But it doesn't mean that doctors are not interested by this, obviously not. But our report will be addressed not only for professionals, but also for patient, public, and authorities. And we will build up on publication 138, which actually precised what were the ethical basis of radiation protection. And while publication 138 was pretty theoretical, in this task group, we want to have something that is practical. We want to have something that is based on the practice and that can be really applied on a day-to-day basis for all the practitioners. So what did we do? We actually started our work 1 year ago in Czech Republic, and then during more or less than a year, we had exchange by email and video conference, and we had the opportunity to meet again last September in Geneva. And actually I have to thank Maria Perez, who is also a member of this task group actually, because she organized a very nice workshop in which we were able to have quite a lot of feedbacks from different stakeholders, and that was really useful. And here you have more or less the table of content of our draft report. It's maybe written in a funny way, you will see, but it helps to see where we go. So we will obviously introduce our work with a chapter of introduction, that's clear. After that, we will precise what are the ethical values. As almost always in ICRP publication, we want to remind what is really important in this case. And in this case, the dose-effect relationship is also important, because if we want to communicate with patients, with anywhere, if we want to communicate, we need to know what is the dose-effect relationship. You will see that afterward. And after that, we will arrive to the core of our work, which is how we can actually, in practice, use ethics to communicate and to do our work better. And after that, we will have 2 chapters of practical example in radiation diagnostic and in radiation therapy. And finally, we will talk about communication, we will talk about artificial intelligence. This is really a subject that is of our time. And finally, we will talk about education and training in order to make sure that this can be done in practice. So if I start with the first point, introduction, what will we have in this introduction right now? Well, we realize that in medicine there is still some paternalism that is present, definitely. And at the same time, the society is evolving. It's evolving toward much more and more autonomy given to the individual. And we realize that if we want to have the good balance between those 2 aspects, ethics is really something that is important to have. And in this introduction, we want to show clearly that ethical guidelines is not sufficient in order to make sure that we are acting in an ethical way. And that's why I don't know if we will have it in the final document, but we found in the literature an extreme case in Nazi Germany. This was a study that was actually conducted by the Radiological Society and the Radiation Therapy Society of Germany, in which they analyzed what really happened during the Nazi period, in which they did forced sterilization, they did tuberculosis screening that led to finally to a lot of people who died. And what did actually happen on a day-to-day basis? Well, they realized that these crimes were actually backed by studies that looked really scientific. There were a lot of scientific papers around this. There were doctoral theses. There were funding that were given to the universities, and that gave them something that looked as being ethics. And I was a bit surprised when I read this paper. At that time, they already had ethical guidelines, and this didn't prevent such action to happen. So that really means, this example is really extreme, that's clear, but that's what really is shown with this, is that having ethical guidelines is not sufficient. We need to keep critical thinking, and we need to have the ethical values that are applied in a day-to-day basis in order for us to make sure that we really think ethically and we don't just apply checklist. Okay, in the chapter 2, obviously we'll have to remind what are the ethical values that are defined by, that have been defined by the ICRP, and these are in publication 138, so if you didn't have time to read them, please find the time to do it. I think it's good. And what do we have in this publication? Well, we have 4 core values. The first one is the beneficence, so do good and no harm. The second one is prudence. Well, for me, prudence is quite important in radiation protection because at first I didn't understand it. For my mother, for instance, prudence is, when I go up in the mountain, is, well, you should not go to the mountain because it's too dangerous. Well, prudence is not this. Prudence is try to make a good decision, taking into account that there are some uncertainties. And this is clearly what we have in radiation protection. Risk zero doesn't exist. When I go in the mountains, risk zero does not exist. But anyway, it can be safe because I assume that it's safe when I take into account all the uncertainties that are involved. And then we have the justice value, well, which asks us to be fair. And finally, the dignity value or dignity autonomy. These are the 4 core values. And we also have 3 other procedural values that have been added. Well, I don't have time to go throughout this. Okay, so in this chapter, we thought it would be very important to make the parallel with bioethics, because people working in medicine, they are used to bioethics. So in this chapter, we will try to make the link between what we have in publication 138 and what is done on a day-to-day basis in medicine. We want also to make sure that the link between the ethical values and the 3 principles of radiation protection will be straightforward. And for the justification, it's quite clear that we want to make cost analysis, cost-benefit analysis, but in our days, in 21st century, this is no more sufficient just to make a brutal cost-benefit analysis. If we want to make sure that an activity is really justified, we have to take into account the dignity principle, and in this case, we have to emphasize the consent of the patients who receive a dose in order to make the risk that is acceptable to them. And that also means that we will need to find new approach in order to explain the risk to the patient, and that will also most likely add some burden on the professional. For the optimization and limitation principle of radiation protection, the link with ethics is more or less straightforward, but an important aspect in finding the link between ethical values and optimization and limitation is what is reasonable. And actually, the ICRP has already a task group that deals with what is reasonable, and that will be a subject in itself, but that is really important in defining what do we do as an optimization or a limitation. The 3rd chapter will be about dose-effect relationship. This is more or less standard and should be maybe well known by everybody, but you will see it's not always the case. Clearly, we will make a small summary of what has been written already in publication 103, but we'll try to go a bit more forward. We'll go to what has been already discussed this morning. How can we explain the risk related to a certain dose. And for instance, we'll take into account the effect of variation of sensitivity in the lifetime. So we had already this graph that was presented this morning by Colin Martin. How can we estimate the risk? Oh, well, we have it for according to the age that is here. But if we want to have just a rough idea of the risk, or an approximate idea of the risk, every time we ask a radiation protection professional what is the risk, the instantaneous calculation that will be done will be 5% per CFET. Even people who think the effective dose cannot be used to estimate the risk, everybody does this kind of calculation. But we can refine actually this kind of calculation. We can refine it by saying, okay, if the person is older, then the risk is lower. Or if the person is younger than the adult population, the risk is higher. So this is what we actually have in the publication that will soon be published, and that comes from ICRP TG 79, which says that we could estimate the risk by doing what we call an approximate indicator of possible risk, which is the use more or less of the 5% perceived, or maybe we can, as I said, multiply the factor by multiply this risk factor by 2 if it's a young person, or even higher if we want, or divide it by 2 if we have a population that is older. But what is important is the name that has been used in the report of TG 79. It's approximate indicator of possible risk. So we clearly see just by the name approximate indicator that we are not very precise, and we emphasize the uncertainty. And I think it's important to emphasize the uncertainty when we are at low doses. And we will also treat the effect of the dose to the conceptus. So this is a summary of the kind of risk we can have as a deterministic risk, because the situation of pregnant patient is usually quite important. Well, it's important to be clear with the patient that are pregnant. Okay, so I will just move on. I don't want to go into this detail. When we talk about sensitivity to the lifetime, we are used to say that children are more sensitive than adults. This is clearly the case most of the time. But when we look at the UNSCIR report, we see that there may be some exception with lung cancer, for which young children tend to be less sensitive than adults. So I think it's important to know what is actually established by scientific fact. And as I said just before, uncertainty is really important when we want to estimate the risk. And uncertainty is directly linked with the principle of prudence. Prudence, as I said when I go skiing, there is some uncertainties, and when we want to estimate the dose-effect relationship, the uncertainty is crucial to be mentioned to the person that are linked with it. And in most cases in medicine, we apply the LNT because we are in the low dose range, and the uncertainty has to be communicated. It has to be communicated to the patient, because informed consent cannot be obtained by a person if they don't know the uncertainty that is behind. So when we say that we can estimate the risk by just calculating 5% perceived, I'm oversimplifying, that's sure. But when we say these kind of things, we also have to mention to the patient that there is a large uncertainty in this estimation. So how do we communicate? I think it's important that we tell what we know, we tell what we don't know, we tell what we think, and maybe more importantly, is that we distinguish well between the three. In general, we tend to mix those three aspects, but if we clearly say the difference between those three things, this is an ethical way of presenting reality. Okay, now I arrive to the core of what we have established in this task group yet. It's reviewing the practice from an ethical perspective. So how can we do in practice to do that. So in this chapter, we want to start with describing some practical aspects. So we want to mention what is professionalism and what we can learn from our error and how we should proceed. But the most important part of this chapter will be to see how we can have an estimation of the ethical aspects of a situation. So for that, we will start with realistic scenarios that have challenging ethical components. And we will see how we can grade each ethical values. So we'll take the 4 core ethical values that we just defined in publication 138, and also the 2 other procedural values, and we'll take each them one after the other, and we will see how compliant the scenario that we are analyzing is. And if we find that there is some compliance for one value, we will put 1 smiley. If we think that there is a good compliance, we'll put 2 smiley. And if we think that there is nothing to mention in terms of compliance with this value, we'll just put a slash here. And we will repeat this for all the values. And then we will analyze each value again, but regarding to its non-compliance. And we'll have the same approach. Some non-compliance, 1 reverse smiley. And if there is a heavy non-compliance, 2 of them. And if there is nothing to mention, we will have this. Okay. So that means that at the end, we could have a broad table of the ethical profile of a given situation. Okay, so this looks a bit maybe theoretical when I just present it like this. Let's see how we propose to do it in practice, in a concrete manner. So in the next chapter, we will analyze different situations in radiation diagnostic. And the first one we propose to have will be adult population, but for each of them, we will have 2 parts. One part will be a description of a scenario, and the second part will be a development on a more general development on the subject in question. So for the adult population, for instance, here I have an example of scenario. So we have this person of 63 years old who moved from one place to another, and he's in quite good health, but he wants to establish a new healthcare network, and therefore he goes to a medical doctor. So this medical doctor finds that not a patient, but Mr. Corral is quite fit indeed, and he would like to establish some baseline, and he says to Mr. Corral that he should take a CT examination of chest and abdomen and pelvis. It is noted that Mr. Corral had no X-rays since for the past 10 years, but his doctor feels that given the advances of technology, these older studies would be of limited values for comparison. Mr. Corral is not really glad about this. He tries to inquire to the value of the CT, but he is quickly interrupted by his doctor, and he said, well, it's total routine, and finally Mr. Corral agrees to have the CT scan. So you see this situation, very simple situation. This is typical of what we propose to have in this chapter. And how can we actually apply this method? Well, as I said, we go through each value one after the other. So for the beneficents, non-maleficents, how compliant are we? Do we find some compliance for this value? Actually, I put a slash here. Some people may say, well, the doctor wants to have the best for his patient, so maybe we could have 1 smiley here, but this is not what I had here. Prudence, precaution. Well, when we see the fact of having some dose added for maybe no real scientifically backed reason, we could doubt of it. So therefore, we put a dash also in compliance. For justice, well, this doctor would probably do the same for each patient. So we can say that there is some justice. For dignity and autonomy, well, yes, this doctor made his best effort to establish a baseline in order to make a comparison afterwards. So it's maybe quite good. For transparency and accountability, from my point of view, there is no compliance in this case. If we go to no non-compliance, beneficence, non-maleficence, there is no proof that this examination will bring real benefits. So that means...
Francois, five minutes.
Okay. For prudence and precaution, only the risk associated to the exposure is present. Therefore, there is clearly no non-compliance here. For justice, well, he would do the same for all of them, so that's fine. Dignity and autonomy, the patient's opinion was not asked, and also there were hints that he could disagree. He more or less decided that the examination should be done. For transparency and accountability, well, we're not sure that the doctor would actually tell this to the outside world. This is not common practice, so we doubt that this would be acceptable. And for inclusivity and empathy, we'd put two fronts in this case, because the patient could not really ask his question. So I thought I had more time, so that means I will just move fast to my conclusion. So if I can do it like this, because I had some other examples.
4.5 minutes.
Oh, okay. I thought you told me I was over. So okay.
No.
Oh, okay. Well, anyway. Okay. Anyway, these were just other examples, so maybe it's not really useful. So, sorry. Okay. So that means we will have then a series of examples coming from diagnostic, coming from therapy, and in which we will do exactly the same. So we will always have a scenario that will be analyzed with these evaluation of the ethical values, and then we will have a broad discussion about the different aspects linked to this precise scenario. And afterward, after having presented all these particular cases, we will actually define some particular aspect related to ethics. In chapter 7, we propose to discuss about communication, because communication is important. Who should be informed and when? Who should talk to the patient and the family? What should be said? What is the difference between informed consent and shared decision making? And how can we have, what kind of discharge instruction should we have? Chapter 8, as I already said, we talk about artificial intelligence. Artificial intelligence is coming more or less everywhere. We haven't really have time to discuss about this, but this will be a chapter that will be also important. And finally, the last chapter, but not the least important one, will be about education and training. So right now it's not really well precise, but we want to make sure that we can identify the relevant stakeholders. The ethical dimension of radiation protection in education training have to be identified, and especially, as I already mentioned, we want to precise how we treat uncertainty, because uncertainty in the field of radiation diagnostic, and also a bit less, but also in the case of radiation therapy, is important. And therefore, in conclusion, I want to say that this document wants to be practical and didactic. Several chapters have already been drafted, but they still need to be discussed within the Commission. However, right now, we already identified at least two key messages. One is that we need to emphasize the shared decision making, not just consent based on a sheet of paper, for instance. And we have to emphasize the role of education and training. We want to make sure that everybody really digest the ethics and live them in a day-to-day basis. And how will the procedure be from now on to the final publication? Well, there will be some internal reviews from the different observers.
Close here.
And the document will actually circulate within not only within the Commission, but you will have the opportunity to read and make comment about the document. Thank you.
No, thank you very much. Sorry for being strict, but we have the other talks, and we have already two questions. I will read the two, and then you can answer both.
Maybe read
The
just the first one,
is it possible to assess for gender bias in medical radiation protection practice? Men and women treated differently, exposed to different risks, issues of equity and justice. And I continue because we have really no time. How do you propose to establish accountability and transparency when justification and optimization are fairly flexible terms and not necessarily simple concepts to document within a legal framework? So.
Well, the gender difference, we know that women are more radio sensitive, that's clear. We have different, different type of cancer are more sensitive to different gender, that's clear. I'm not sure I really understood this question. There will also be bias between men and women and different health situation, I'm sure, but no, I don't have a precise answer to this question. And the other one, well, if I understood well, it's already difficult to justify and optimize. How could you expect to also be able to be transparent and accountable? That was more or less the question.
Yeah. How do you propose? But I think
you will have to discuss this during the break because really we consumed all the time for this talk.
Sorry.
Thank you very much again, Francois.